I was
But
missing.
24 में I am certainly come.
Okay, that is in Calcutta.
Calcutta.
23 में उड़ीसा में हुआ था, वही सेम वेन्यू में हुआ था,
I know.
फेयर लगून में.
Confusion हो गया, पता नहीं क्यों.
Sir.
Sir, good evening. Hello, Mehta, sir.
Hello. Anil, your screen is little inverted. I think you have to.
You need to rotate it 90 degrees.
Hello.
90 degrees.
How are you?
Hello, Dr. Choudhary. How are you? Good evening.
Good evening. Hello, Mehta, sir. How are you?
Yes, I am fine. Thank you. And how are you?
I'm not too bad. Good to see you. Active.
Good. Very good. I think I met you in last conference.
Yes, I think that was Delhi, wasn't it?
Yes.
I'm hoping to come for the Jaipur conference.
Jaipur?
Yeah, this year the Neurovascular is in Jaipur.
Okay. Yes.
So it will be easy for you to attend actually.
Yeah. Yes.
Hemant Bharti is the chairman.
You know, he told me. Yes.
Yes, sir.
Yes, I will be there.
Yes, sir.
And what's in Kolkata, sir? When and what is in Kolkata?
NSI. December.
National Conference, Neurological Society of India, annual conference.
Oh, okay.
I think that will be 72nd annual conference. Sandeep Chatterjee is the chairman.
Okay.
Anil, the first speaker is there. He has already joined.
Yeah, Dr. Arun is there.
So all panelists have joined.
Dr. Mathuriya has not joined yet.
Just give me a call if you can, and so that it's 2 minutes there.
Yes, sir. Yes.
Before starting, I think Anil, you give a introduction of our panelists to the listener, whoever the members who is attending the webinar, particularly Professor Mehta and Dr. Choudhary and Dr. Mathuriya. Are you hearing me?
Yes, sir. Mathuriya sir also has joined.
Then it's fine. I think who else is supposed to be the panelist?
Dr. Dhandapani.
Dhandapani from Chandigarh.
Dr. Dhandapani and Dr. Rajpal has not joined yet.
Okay,
so I think we can start.
Yeah, just give a brief introduction of the today's talk and the speaker and the prestigious panelist. Then we can invite the first speaker.
Yeah, a very good evening. I welcome all the esteemed panelists and speakers. So today we will be discussing about aneurysm surgery, prevention, recognition, and management of complications. So we have panelists with us who need no introduction. Professor V.S. Mehta sir, Mathuriya sir, and Dr. Kishor Choudhary sir, and Dr. Dhandapani and Dr. Rajpal will join soon. So now I would like to invite Dr. Arun for his first talk on complication of endovascular treatment for intracranial aneurysm. Dr. Arun, you can start sharing your screen, please.
Hello.
Yes, please.
Anil,
Your screen is not visible actually.
Screen is not visible. I'm just 1 second. Hello, Anil, is it now visible?
No, it's not visible now. Sir, meeting start हो गया sir. हाँ, yes, sir.
Hello.
No, your screen is not visible actually.
Yes. Now, I'm just opening my
Now,
presentation.
yes, seeing you,
Sir.
so automatically your screen will be. You share the screen from the computer down. There is a share
Yes,
screen.
sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. I'm just sharing it. Is it visible now, sir?
Yeah,
Yes, visible now.
Yes.
I'm just
you make
switching
it full
to
screen now.
yes, slideshow. Good evening, everyone. I thank Cerebrovascular Society of India, the panelists, esteemed panelist, and Dr. Anil Sharma for the opportunity. I mean, it's an honor to share the platform with such senior and accomplished colleagues, and I'm eager to listen to the next talks from the more experienced experts in management of complications. From my side, today we are going to discuss about complications from a beginner's perspective. Complications of endovascular treatment of intracranial aneurysms, how to prevent it, recognize it, and manage them from a beginner's perspective. As a beginner, whenever we start endovascular treatment of aneurysms, a lot of things are at stake, and even a single complication can be a setback in your career as an endovascular neurosurgeon. Hence, identifying these complications and recognizing them and limiting the further effects of these complications are very important. So, I mean, as we all know that because of ISAT and BRAT, more and more number of aneurysms are being selected for coiling as well as the
Hello,
current.
sir, can you tell me your login ID, sir? Yeah, now I can see. No, now I can see. Now I can see, sir. I am promoting you to panelist, sir. Yes, sir. Hello, sir. Good evening.
You continue.
Hello. Yes. So with I mean, as
Sir,
we
good
are,
evening,
as we
sir.
are
Sir, meeting
on.
started. Sir. Hello.
Anil, the speaker
Hello.
is getting disturbed. So you allow the speaker to speak.
Hello.
As we all know from ISAT and BRAT and other randomized control trials for rupture intracranial aneurysm, more and more aneurysms are being selected for endovascular coiling. With advances in technology also, there are very less number of aneurysms which are actually deemed as uncoilable. However, in our setting, in Indian setting, because of the financial implications, there is a good number of aneurysms which are getting clipped, as well as endovascular procedures are also on the rise. And in the future, with the more evidences supporting the unruptured intracranial aneurysms, even they will be they will also be undergoing more of endovascular treatment as compared to open surgical procedures. So the layout of the talk will be like first we will look at the risk factors that are associated with the complications associated with endovascular treatment. The complications as such are being divided as access-related complications, procedure-related complications, and whatever techniques that we have, bailout techniques, to limit the effect of these complications. So any complication happens mainly because of lack of understanding of the pathology and lack of understanding of the lack of clear-cut system to limit the problems. So when we are trying to treat with a new modality, all facets of the modality and the armamentarium that we have should be clearly understood to use it effectively. And a standard operating procedure has to be in place and it has to be rigidly, strictly followed obsessive compulsively followed so that any kind of complications can be limited and reduced. So in general, patient and operator related risk factors are very well known for endovascular management. The risk factors and the patient related risk factors are patients with previously known TIAs and previously known subarachnoid hemorrhage, has around 3.7% and 1.8% increased risk of periprocedural morbidity and mortality. Also, presence of increased blood pressure, hypertension, systolic blood pressure more than 160, and cardio and diabetes mellitus has an increased risk of periprocedural morbidity via the endovascular route, which is around 2.3%. We also know that the hydration status and the experience of the operator also has some effect on the overall outcome in endovascular procedure. This is an interesting trial by Bijinki, who has compared the effect of age on the outcome of treatment of unruptured intracranial aneurysms. And it is very clearly seen that as age progresses, the complications associated with clipping is significantly increasing, as well as with coiling. Also, the complications, morbidity as well as mortality goes into double digits with increase in age. So it is more of a common sense that with increase in age, the risk of treating the aneurysm is more than the natural history as such. And endovascular mortality, the risk of endovascular mortality also increases. There is another very old classic study which clearly says that the duration of a procedure has a significant impact on the associated complications. Anything that that is more than that takes more amount of time has more associated complications. For audit purposes and for our documentation purpose, the risks can be the complications can be classified as minor complications. Minor complications are the ones which does not require any therapy or does not have any significant consequence, or with managed with just a nominal therapy, as well as major complications, which includes permanent adverse sequelae and death. So when we go to access-related complications, we have the most common modality of access is through the femoral artery, femoral puncture. We also many centers use radial access for both diagnostic as well as interventional procedures, but femoral is the most commonly used one. The most common access-related complication that we have will be groin hematoma, and if the access is a little on a higher than the safe zone, then there can be chances of retroperitoneal hematoma, pseudoaneurysm, and AV fistulas can happen if we try to access on a lower than the safe zone. As such, access can be done using three techniques. One is by palpation. You have to palpate the common femoral artery with routine anatomical landmarks. You can also use radio or X-ray. X-ray is the most commonly used technique. So you localize the center of the femur at 1 centimeter near to the femoral head is where the common femoral artery is located. And the safe zone for puncture is between the upper border of the pelvic brim and the lower border of the head of the femur. This is the safe entry zone whenever we want to cannulate a common femoral artery. The other one is ultrasound guided. Ultrasound will clearly delineate the axis, and we can do a safe anterior wall puncture. So whenever we have an axis, whenever we are planning for an access, all the access sheath and wires, everything that is required should be available on table, cleaned, and everything with brush. Always keep prepared both the groin, just in case if you are finding it difficult from one side. And X-rays are mandatory in all the cases, and you can use ultrasound as and when, depending on your comfort, whenever you need. And whenever there is a resistance to pass, advance the wire. Don't push it. You have to wait, stop, and then probably use an ultrasound check, and then go for further access. The outcome of a proper access is mainly based on whether you are able to get a proper ventral puncture and whether the puncture is right over the femoral head. This decides the outcome. If the puncture is somewhere on the sides, like for example, you can see in this picture, if it is on the side, or if it is closer to the vein, or if it is little lower down, If the access is a little lower than compared to the safe entry zone for common femoral artery, there can be something called a pseudoaneurysm, where which can be identified by enlarging groin hematoma, which is within the first 24 to 48 hours. The modality to diagnose it is using ultrasound, where you see this classic yin and yang sign. And the treatment for this pseudoaneurysm is usually ultrasound guided compression, prolonged compression over the aneurysm, ultrasound guided, or ultrasound guided injection of thrombin. Activated thrombin can be directly injected into the pseudoaneurysm for this to block. When the access is over, again, if you have a very lower down access, these crossing veins, femoral vein crossing over the artery, can also get punctured along with on the way, and they can cause this AV fistula. Lower down access can cause this AV fistula. AV fistulas are usually asymptomatic, but when they become symptomatic, patients will present with swelling, other high flow signs, and surgery is the main modality, although endovascular treatment is also possible. If the puncture is higher than the routine access point, then there can be injury to the infraepigastric artery vessel, and there can be formation of a pelvic retroperitoneal hematoma, pelvic hematoma. They can present in two ways. If it is along the iliopsoas muscle, they can present as a compression over the neurogenic structures and can cause neuropathic pain, weakness, etc. And if it is a more significant bleeding, then patient will present with hemodynamic instability. So both these cases will require exploration and direct repair of wherever the puncture site is. The other possibility during access is there can be vessel wall dissection, there can be intramural contrast injection, guide wire and guide catheter can penetrate and injure the vessel intima. So careful manipulation is required. If it is significant injury, then stenting is considered. There can be allergic reactions to contrast. The allergic reactions to contrast is less when intraarterially compared to intravenous. And if the allergic reaction is severe, you will manage it like a routine anaphylactic reaction. And heparin also can cause two types of heparin-induced thrombocytopenia. In type 1, it is more of a transient one, which happens within the first few days of heparin. It just corrects on its own without any active treatment, active intervention. In type, the other one, where the type 3 variant of heparin-induced thrombocytopenia, there is an antibody formed against the heparin platelet factor 4 complex. This happens a little delayed between day 5 and day 10, and after starting heparin. So the treatment is withholding heparin, and if at all anticoagulation needs to be continued, alternative sources of anticoagulation needs to be done. Contrast medium also can cause complications when in patients who are dehydrated. And contrast-induced nephropathy or acute tubular necrosis, it is defined when there is an increase, 25% increase from the baseline creatinine after injection of contrast medium. This is a little rare. However, in diabetic patients already having nephropathy and patients who are on metformin, these contrast-induced nephropathy complication can happen in a more significantly higher number, and that can affect the overall outcome. So that is radiation-induced skin damage is also one other complication. So this is the routine reported rates and the threshold limit beyond which these complications should not happen, which is somewhere between 1 to 3%. Everything, all these mentioned complications right now are around less than 1%, and whenever this threshold is more, we'll have to review the system where exactly we are going wrong and use more stringent measures to avoid crossing this threshold limit, so that the further procedure can be done in a more smoother way. So once we get proper access with various catheters, because the talk is more on complications of aneurysm surgery, I'm not going in detail about the different catheters that are required and how we are going to access difficult arches. So consider that we have reached the main vessel, and where we set in this coaxial or triaxial system. So each of this system has a Y connector as well as a flush line. And all these, this is a triaxial system where along with the coaxial system, you have a microcatheter and micro guide wire. All of them connected to flush line and with the connector. So all these are potential points for formation of clot and emboli. So we have to be obsessive about continuously monitoring this Y connectors as well as the flush lines for air bubbles as well as clots, because this will eventually affect the overall outcome. You can do a procedure very nicely, but in the end, if these kind of small issues which are overseen can adversely affect the outcome. The next, the most important one, rupture of vessel. So one, you have reached the vessel, reached the aneurysm, reached near the aneurysm, and there is this rupture of aneurysm. So usual incidence of rupture of aneurysm is not that much. It is around 2% in a rupture aneurysm and 0.2 to 0.5% with an unruptured aneurysm. The rupture usually happens because of three things. You have taken the whole system, the triaxial system, up to the point. So the rupture can happen either because of the guide wire or this microcatheter or because of the coil. Usually the rupture that happens because of guide wire, the guide wires are very soft, and the ruptures that happen because of them are very small punctures, which are not that catastrophic. However, the ruptures that happen because of the microcatheter or the coil are significantly bigger ones, bigger rents, and there can be significant bleeding because of ruptures because of microcatheter and coils. So how to prevent it and how to avoid it is what we will briefly see. Before that, I just wanted to point out this small statistic from the recent re-rupture in treated aneurysm carrot study, re-rupture cerebrovascular re-rupture in a treated aneurysm study, recent study, where there is a 4-fold increase in mortality compared to surgery. There is a significantly 4-fold increase in mortality and morbidity when there is a rupture in endovascular treatment as compared to open surgical treatment. With surgery, there is a 2-fold increase, and with endovascular modality, there is a significant 4-fold increase. So how do you identify this rupture? You first see whether there is any breach in the, you do the whole procedure on a roadmap, and whether if there is any breach in the construct or breach in the vessel wall, breach of the coils or the microcatheter across the shadow. You'll have to see that, and whether there is any abrupt increase in the blood pressure or pulse rate. If both these signs are present, then presume there is rupture. And if you can identify the rupture, immediately go for salvage methods where you can coil and control the hemostasis. If you're not able to do that, usually all these patients will be on heparin, which we will discuss in further slides. So that has to be reversed immediately, and then again salvage measures has to be taken to control this rupture. So there are other things, other ways to identify it is sudden change in hemodynamics, and then there can be fresh blood in your external ventricular drain if there is a drain kept. So what are the features of aneurysm that decide the treatment and decide the complications related to the treatment? So basically, if it is a wide-necked aneurysm, whether it is a wide-necked or a narrow-necked aneurysm, which is basically decided based on the measurement of the neck. If it is more than 4 millimeter, it is a wide neck aneurysm, and if the dome neck ratio is less than 1.6, it is a wide neck aneurysm. In case of a narrow neck aneurysm, you won't need a significant number of additional hardwares, so you can just do a direct simple coiling. So with simple coiling, the less the amount of hardware, the less the amount of complication. So you can go and do a simple coiling. If the aneurysm dome, if it is a wide neck aneurysm, if it is a wide broad dome neck ratio, then you will require additional modalities, adjuncts to treat the aneurysm, and which will add on to the complication risk. So this is an example of one of our case that we have done. It is a ACOM aneurysm, which is a quite narrow neck aneurysm, which was treated with a routine simple coiling with just a single coaxial system. There is a guide catheter at here, and then with a microcatheter, we have coiled the aneurysm. The second thing that we have to look at is the working angle. Working angle is very important to first position our construct, position our whole hardware in a proper way, and deliver the coils in a proper way. The ideal working angle is one where the parent vessel and the neck are clearly separated, the aneurysm and branches are separated and the images are fully magnified, and there is no overlap between the neck and other associated vessels. And all devices, including the guide catheter, are in the field of view. So this is one where the working angle is not suboptimal working angle. We had coiled this ACOM aneurysm, where if you can see this, we are not able to. We are able to see the opposite side A2 here, but the origin of opposite side A2 is not very clearly seen because of the difficulty in positioning the C-arm gantry. So once this aneurysm is coiled, the opposite side A2 was not very clearly seen, but however, luckily the patient had a very good flow from the left side. This is the right side. We have coiled from the right side, and the left side was a good flow, and the aneurysm was also secured. The other thing about this aneurysm is it is a small blister kind of aneurysm, and the positioning of microcatheter plays a significant role in seeing whether there can be any rupture or not. So ideally, the aneurysm microcatheter should be between one half and 2/3 of the aneurysm dome inside the aneurysm, and the microcatheter should not have too many curves, and it should be more smoother. So if there is a microcatheter with too many curves, there can be high chance of kickback, and this microcatheter, when it kicks back, can puncture and rupture and come outside. So to avoid that, you can use a distal access catheter that supports the microcatheter with which gives it a more smoother curve and does not and avoids this kickback. So these are the few things that we have to keep in mind when we position the microcatheter. And the other way to position the microcatheter in a side wall aneurysm, straight wall aneurysm, end-on aneurysms, branching aneurysms, where we can directly go and position the microcatheter without any significant difficulty are okay. But when the aneurysm comes in a side wall like this, you'll have to shape the microcatheter accordingly, and never access the aneurysm with the micro wire. Position the microcatheter, position the guide wire, position the microcatheter distally, make the microcatheter come back to its required shape, and then gradually slip it inside the aneurysm to avoid any unnecessary puncture of the rupture of the wall. So this is usually microcatheter comes with a mandrel which can be inserted into the distal tip and can be steam shaped using a steam, and there are pre-shaped microcatheters also, but even if there is no pre-shaped ones, it can be steam shaped using this mandrel. So the other one is when there is a complete prolapse of the coil. This is one of the cases that I have seen recently here. So where you see that the coils are prolapsed outside, and you can see this contrast coming out with the flush. The other method of when this happens, what can be done? There are two things that can be done. Whenever there is a puncture, even after taking all these precautionary measures, there can be punctures, there can be ruptures. When there is a rupture, when there is a puncture of the microcatheter or the coil, avoid the impulse to pull it immediately back. Leave the microcatheter in place. Take another microcatheter and first secure the aneurysm, and then pull back and complete the coiling, or take another microcatheter with a balloon, inflate the balloon, and then complete the coiling. These are the two rescue methods that are routinely used in case of a ruptured aneurysm. The other, in case of unruptured aneurysms, stent also can be deployed all across, and then further the neck can be narrowed, and coils can be deployed accordingly. The one thing that has to be understood is the tip of the radio opaque tip that we see in a C-arm. That beyond that there is some more further tip extending around 0.5 to 1 millimeter. So that is that has to be kept in mind when we are advancing the microcatheter into the aneurysm. It should not be too much inside. It should not be too much outside also. If it is too much outside, like in this case, there is a prolapse of aneurysm coil outside. And there is the aneurysm wall is also, the proximal and distal wall is also significantly bigger than any available stent. So in these kind of cases, you have to probably undercoil the aneurysm using a balloon assistance or balloon assistance rather than flow diversion. The ideal embolization ratio that is required to completely cure an aneurysm is around 30%. Anything more than 30%, you have a risk of rupturing and causing significant bleeding. Anything less than 30%, there is high chance of recanalization. So we have another patient where this the patient presented with a recurrent ear bleeding, and there was a pulsatile mass seen in the ear. You can see there is a petrous IC aneurysm. 77-year-old gentleman. He had undergone coiling. I had left a small residual neck because we were not able to. It is a wide neck, and I was not able to place any stent or stent across. And because of financial issues, we were not able to afford for a balloon. So we had undercoiled the aneurysm, and the patient went home fine without any major issues. But again, after a month, he came back with significant bleeding. So significant ear bleeding, and he was hemodynamically unstable. Luckily, we had done a complete study on the pre-op where we could do a cross-compression study, and there was a good cross flow. So we immediately exposed the neck and sacrificed the parent vessel, and the patient patient survived and went home without any further deficits. So main thing is we'll have to clearly plan and prepare for all kind of eventuality, including parent vessel sacrifice when we plan for this. Plan for endovascular management of aneurysm. Sometimes glue are also used when there is a rupture in aneurysm. Next complication is thromboembolism, which is around 1 to 2.6% of all cerebral angiograms, and permanent deficit is present in around 0.5%. How do you prevent? You keep all the flush lines filled with at least each liter of flush line filled with 1,000 units of heparin. And you give an intravenous pre-operative bolus dose of heparin based on ACT. Usually the ACT is kept somewhere around 250 to 300. You give a bolus dose of 80 units per kg at induction, and every hourly you can top it up with around 10 units or 15 units of heparin. Based on ACT also, we can titrate the heparinization every hourly. The ideal ACT level is around 250 to 300. And when we are planning for a stent-assisted or a web device, we usually use antiplatelets rather than anticoagulation. Anticoagulation is also used, but antiplatelets is given for a long-term effect. We routinely use dual antiplatelets, aspirin, as well as clopidogrel. The sensitivity for these two are checked using this Verify Now, where they genetically people are susceptible. The reactivity to aspirin and clopidogrel differs genetically based on the enzyme inhibitors and enzyme stimulators. So this can be checked using this Verify Now system, where the optimal level of drug effect is, if it is low, then probably instead of a dual antiplatelet, you may have to increase and give a third antiplatelet. So this is one more. This is one very catastrophic complication that we had faced for this patient. It's a 53-year-old lady. She presented with a SAH in the right cerebrum fissure. We had immediately opened and clipped the MCA aneurysm. There was an incidentally associated distal AC aneurysm also, which she had come back after the clipping around 2-3 months later. She had come back. You can see the MCA clip here. She wanted specifically for coiling of this distal AC aneurysm. Yeah, it was coiled. Coiling was uneventful. We used immediately after coiling, after probably around 10 minutes, when we did a check, and there was a progressive reduction in flow of across the ACA, and after some time there was complete obliteration. So we immediately started. We thought of embolus, thromboembolic phenomena. We immediately started tirofiban intra-arterial tirofiban infusion, followed by intravenous tirofiban infusion over 24 hours. It opened up, but still she had developed ACA infarct, and she needed a decompressive craniotomy. She had a very poor outcome. She had come intact, and then she did develop a poor outcome. So one possibility is we had we had reused some of the wires and catheters from our previous available stock. And when these wires and catheters are not cleaned and flushed properly, there can be chances of distal embolus and occlusion of parent vessel. This was one such case where I regretted doing endovascular, because patient was completely normal with the first open surgery, and maybe I could have offered and pushed the patient for open surgery. rather than endovascular. This is one catastrophic complication that that can happen when you don't clear and clean the wires and microcatheters regularly. So distal vessel injury is also one of the one can happen, and when there is a because of overinflation of balloon, because of perforation of your anchoring catheters, anchoring wires, anchoring guide wires, distal vessel perforation can also happen. Whenever possible, you have to clearly keep the distal vessel in your view and avoid overinflation, and continuous fluoroscopic monitoring of guide wire tips needs to be done to avoid this distal vessel injury. Treatment is reversal of anticoagulation, and like routine, how we treat the other perforations and bleeding, this also has to be treated in the same way. So in summary, patient selection for endovascular treatment is very important. Meticulous planning is important. We'll have to be prepared for all eventualities, anticipate all the complications. Technique has to be meticulous, and after each and every case, there has to be a debriefing to see where things could improve. System has to be a clear system has to be established, and your staff has to be regularly exposed and they have to be trained for the endovascular procedures. And you should always live in a constant fear of air bubbles and clots in the flush line. This is something that that I am always paranoid about and keep looking at, and that is something that is a completely avoidable complication that can happen with endovascular procedures. So thank you.
Thank you.
Thank you very much. So as I can see, there is no question. So I request all the panelists for their comments and discussion.
I think Dr. Arun Kumar, what a wonderful presentation and such a realistic. I really enjoyed every word and all the slides that you presented. And they are so important for anyone who really wants to start endovascular intervention. Thank you very much. It was very eye-opening and wonderful presentation. What I would like to say, what we do is that we had one complication from a groin hematoma where patient required an above knee amputation eventually after a simple DSA that was carried out. This was about a year ago, but that did happen. Patient was under my care and had a PCOM aneurysm coiled and was just had a check angiogram and required amputation eventually because of the DSA. And what we do for the aneurysms that are unsuitable or deemed to be unsuitable for endovascular intervention, or if our radiologists are not sure after CT angiogram whether they will be able to succeed or not, we consent them dually. So we consent them coil or clip. So if for any reason patient is not able to have the coiling, or if the aneurysm morphology is not suitable, we take the patient straight to theater and carry out the clipping after the angiogram. And we don't do that on every patient, but wherever the radiologist is unsure, interventionalist, this is the strategy we apply. And we keep the theater ready for that. A surgeon is kept ready as well. And I think it works very well. So, but wonderful presentation. Thank you very much.
Thank you. Thank you, sir.
And any comments, sir? Mehta sir, Mathuriya sir?
Hello, can you hear now?
Yeah, yes, sir. Yes, sir.
Okay. No, I'm saying that's a very nice presentation.
Yes, thank you, sir.
Truthful. And as I said, because you are a neurosurgeon and doing this, probably you have given the truth. Now, my only some comments or question would be that what about the brachial route in such patients? Can you do it routinely through the brachial route or no? Number one.
Yes, sir.
Number two, one of your slides showed meningitis to be 16%. I think it's too high. Is that correct figure, or I read it incorrectly?
Meningitis, sir?
In complications, you said meningitis 16%.
No, sir. Not
No?
meningitis. No, sir. No.
One of the slides check that. Anyway.
Okay, sir.
Okay.
The brachial root, distal radial artery, and brachial artery is not routinely used, sir. Now people are using more of a radial artery as well as distal radial artery, the snuff box approach, where the snuff box is used. The patient is able to get mobilized in get mobilized early, and the complication rates are comparable to femoral axis. And whenever there is a difficult arch where they are not able to access through femoral artery, radial artery helps in radial artery becomes a bailout technique, and it becomes more easier. But most of the procedures are possible through radial artery. The learning curve is a little more steeper. And
Girish, Rajpal have not joined?
I think he has not joined, sir.
Okay. Dhandapani?
Hello, sir. Hello, sir. Sorry, sir. I joined from my friend's device, so I couldn't be kind of promoted to panelist. So I had to log out and then log in again.
Okay. You have any comments?
No, sir. I think most of the things has been covered. I think the results also, all the kind of because already we are kind of late. I think we can go to the next speaker.
Okay, thank you. The next speaker, Dr. Sharat.
thank you, sir. Thank you.
Dr.
So
Sharat.
actually, due to some last minute emergency, like some family emergency, he had to rush to Bangalore. So
Okay.
he has sent his pre-recorded
Huh.
talk he has sent. So he agreed to send at last minute. He prepared that and he sent it so that we need not to modify our webinar, our schedule. So
Okay.
he sent his pre-recorded talk that we'll display.
You want to now do it now? Or?
Yeah, now listen. You can start, sir. Aklan, you can start. Yes. You start. Start. So Akhila, can you start sharing the screen? Akhila, are you there?
Okay, if there is some
Sir, I'm there. I'm just sharing the screen, sir.
Yeah, please start. Please start.
So just confirm me whether the screen is visible or not.
Yeah, visual, please.
yeah,
please.
visible.
Okay.
You
Okay. I hope this is audible, no, sir?
Yes, yes.
Okay.
So volume you need to check, Akhila. We cannot hear.
Sir, volume is high only, means maximum volume I have.
No,
We
but we
can
cannot.
hear you, but there is no voice of Dr. Sharat Chandra.
So voice, you like voice is not coming or
No, it's not
not
coming.
able to.
It's
Voice
not
is not coming.
Hmm.
Just a minute, sir. I'll share again once.
Now, while sharing the screen, there is an option of including the sound, because otherwise only the slides are shared. So you'll have to select that option.
Yes, sir. Already I have done that. Still, I'll just check once. I'll start once again, sir.
So good evening. Today I would be presenting about intraoperative
Sir, is it
aneurysm,
audible?
Yeah,
Now,
yeah.
now.
most
Okay.
feared complications for any aneurysm surgeon, and would also be talking about my own personal experience and how to prevent it and how to tackle it while taking care of this complication. So my own experience with aneurysm surgery has been more than 2000 cases, and my own personal incidence of intraop rupture has been 8 to 9%. Now, I have found that initially I would find it very difficult to tackle with intraoperative rupture, but over a period of time, I found that sometimes we may even have to do an elective rupture in order to apply the clip properly. So obviously it has to be tackled at 3 levels. So one is at a psychological level where the surgeon, that is very important, because psychologically, if the surgeon is not well trained or not prepared, he or she would not be able to, tackle this complication properly. And at the surgeon level, it is very important that whenever you have an aneurysm rupture, you should not pack that area with some kind of a gauze or cotton. It is very important that one should use a double suction. The suction should not get blocked. And it doesn't matter if it bleeds a bit. And one should have an array of clips. Sometimes it may be necessary to continue with dissection even though there is a rupture. And then finally tackle the rupture by applying the clip. From an anesthetist perception, from the anesthetist point of view, it's very important that no hypotension should be created. Adequate cerebral protection should be given. And of course, the whole thing should function as a proper teamwork. There should not be any need to have any panic or to shout. Now, surprisingly, if you go through the literature, there are very few articles which have been published which deals about this complication. Now, what are the aneurysms which are at risk for rupture intraoperatively? It could be a blister aneurysm with a hematoma that has a really high risk of rupture, especially with history of warning leaks. Or there could be an aneurysm with multiple lobules, or aneurysms which arise from ACOM, which is stuck anteriorly and inferiorly to the plenum. Now, the time of aneurysm rupture, it could be firstly craniotomy. So the incidence of rupture at the time of craniotomy is around 5.3%, and that is a very difficult area to control. Or it could be the time of opening of dura or subarachnoid cisterns, or it could be during the time of hematoma removal, which again this is a common cause of aneurysm rupture. Or it could be during the initial microdissection, or it could be during the definitive microdissection. Now, this is the commonest reason for aneurysm rupture when the dissection is being performed. Now, others could be multiple other causes. Now, we could look at each one of them, starting from the last point onwards, which is clip and clip manipulations. So applying the clip wrongly. So here is an aneurysm which I approach through the minimally invasive approach through the eyebrow incision. So it was a straightforward anterior communicating artery aneurysm. So expose the ACOM, and that's the Huebner's artery. So you could see that I defined the neck both anteriorly and posteriorly and applied a clip. Now, when I dissected the aneurysm, I found that the end of the clip was taking up a vessel. So obviously now I wanted to readjust, but the mistake I did is I applied a clip more distally, and that led to a rupture at the neck of the aneurysm. So obviously I had to now readjust the clip properly so that there is no bleeding. So this is a could have been a very dangerous situation, and one has to be very careful not to commit such kind of mistakes. And the clip has been, you can see, has been readjusted again. Now, this is one of the techniques which has been described whenever you have rupture at the neck of the aneurysms, which is one of the most dangerous type of ruptures you can have. So one mechanism is that you could apply this kind of a clip along with a Teflon patch, which holds the rupture at the level of the neck. Now, this is an example of a basilar top.
What happened? Voice is gone.
And this is exposing the neck of the basilar artery. Now applying a temporary clip on the trunk of basilar artery. And now you can see that while I was adjusting the aneurysm clip, there was a sudden rupture. So here, every time I was trying to manipulate the clip, it was slipping from the coils. So ultimately we had to open up the coils and cut the coils, and finally apply the clip directly on the coils in order to provide a proper clipping of the basilar neck. Sorry, I was out of the focus over there. I didn't realize it in the mic. See that finally we applied the clip directly on the coils in order to secure the complete aneurysm. Now another example of rupture during clipping or clipping manipulations. So this is a left superior hypophyseal aneurysm, large one. So we were drilling the Clinard process. Now the problem was I did not expose the aneurysm completely. So the neck was not completely exposed and there was a sudden rupture because the clip was not applied properly. This could have been a very, very difficult situation. So again, when I was trying to apply it onto the neck of the aneurysm, I could not apply it, secure it completely because the dissection was not complete. So it's very important to perform a complete dissection before you think of applying the clip. So you can see I was trying to dissect the residual aneurysm and there was suddenly a rupture. And we had to again readjust the clip and finally we were able to control the bleeding from the aneurysm. So we had to use a reinforcing clip that took care of the aneurysm there. So again, we did this through the eyebrow incision. So sometimes you could have a vessel stuck to the aneurysm. So in this case, you can see it's a complex aneurysm and you could see one of the arteries was actually stuck. It's a large ACOM aneurysm to the anterior communicating artery. So while dissecting, there was a rupture from the other side of the aneurysm. And the aneurysm you could see was having a very large sac, which was dysplastic. So we started coagulating in order to shrink the sac of the aneurysm. And you can see the ACOM was very complex with a large dysplastic sac. So we continued dissecting so that the entire neck was completely exposed. And then finally we had to apply 2 clips in order to secure the aneurysm. There was a small dysplastic bulge over which we put some glue and put a muscle patch in order to secure it because it was not possible to isolate the aneurysm completely because the whole ACOM was completely. Now during definitive microdissection, that's the time when almost 1/5 to 1/4 of the aneurysms, they rupture. So this is a carotid cave aneurysm. So in this case, the clip was applied before complete dissection. That was a mistake here. So they're drilling out the ACP. So I drill both intradurally as well as extradurally first, and then applying a temporary clip. And you can see that the clip was not applied properly and the neck was not exposed properly. So then we continued with the dissection, exposed the residual part of the neck and advanced the clip in order to
हे मी तुला एडिट करून देतो माझं हे होऊन जाऊ दे कारण बाकीचे पॅनल्स म्हातारेच आहेत.
Now, during initial microdissection, also you could have a rupture that is relatively a difficult thing to tackle. So here, the ACOM, we were trying to dissect the ACOM, and before clip application, the whole aneurysm ruptured. So you could see a very thin aneurysm with a large bleb. So just in front of our eyes, the whole aneurysm ruptured. So it could happen like that whenever you have a aneurysm which is a very thin wall and a dysplastic. So in this case, fortunately, because most of the dissection was already done, so you can see that we keep a suction in order to keep the field very clear. Do not go into a state of panic and start packing the whole area. We apply a temporary clip on the A1. Continue dissection. That's only for a few minutes. And then we remove the temporary clip in order to prevent hypoxia. And you can see that the aneurysm had sealed off itself by placement of, now we were able to dissect the neck completely. Now the cotton is kept over the fundus of the aneurysm. So keeping the cotton on the fundus of the aneurysm, we were able to completely expose the aneurysm and then secure the aneurysm properly. So sometimes while removing the hematoma, an aneurysm can rupture. So this commonly happens with the DACA aneurysms. So DACA aneurysms, they commonly present with hematoma, and whenever one tries to evacuate the hematoma, that is when the aneurysm can actually rupture. So so this is a DACA aneurysm, which is a large thrombosed part. So you could see we expose the thrombosed part. And then while evacuating the hematoma, the aneurysm completely ruptures. So that's the intraop rupture. So again, the technique should be to use suctions in order to keep the field clear. Again, no packing, no panic. So one should be, very clear-headed in order to tackle issues like this. Go right up to the continue dissection. Expose the neck of the aneurysm. Once the neck is exposed, applying a clip, and after that, obviously, the bleeding stops. So even if the clipping is not perfect, you could apply an imperfect clip, continue dissecting, and then readjust the clip. That is much more better than putting a temporary clip and creating the possibility of hypoxia due to prolonged temporary clipping. So that's the post-op. You can see the clip in place. Again, that's the AP view with clip in place. So then finally, we find that we had to readjust the clip. So that is the time we applied the temporary clip. And it was only for a few seconds. So just applying a temporary clip proximally and then readjusting the clip properly. And then, of course, we excised the thrombosed. End of surgery. Now, while having a rupture during the craniotomy is one of the biggest disasters you could have. Similarly, you could have now that it's very difficult to tackle such cases. So sometimes you may even have to do a lobectomy in order to tackle such emergencies. Now, it's very important to select the right size. So you have to understand that SRK clip is not effective near the hub. It is most effective near the tip. So ideally, the clip should be, this length of the clip should be longer than the neck of the aneurysm. And the aneurysm should be clipped in the distal 2/3 to 1/3, 2/3 to half of the aneurysm clip. So this is how the ideal clip should look like. So there should be an area of the clip which should be not used for the aneurysm, which is more proximally. So what the aneurysm clip should not be exactly the same size of that of the neck of the aneurysm. So other strategies is sometimes you could use D-Bakey's cardiovascular hemostatic clip, sometimes for rupture of large or giant aneurysm, but it's a temporary measure. Now, obviously, the tips to prevent rupture are very, very important. So it's very important to put a temporary clip at the right time. It's important to identify the neck completely before you go ahead with clipping. Otherwise, you could see that you could have some accidents like I have shown, which you could have on the videos. Sharp dissection is always preferable. And you should know the clipology. So you should know which is the right clip to apply. So if you follow these 4 tenets, of clip application, you can even take care of the most complex aneurysms even from the very small openings. For instance, this was a complex ACOM aneurysm, and we clipped it through an eyebrow incision using just the size of 3 into 4 centimeters opening. So again, you can see that just from a small opening, we were able to clip the aneurysm. So tackling intraoperative rupture is more of a state of mind. So one should face it and know it. So if you operate aneurysms, you will face rupture one day. This is very similar to Helen Keller saying that avoiding danger is no safer in the long run than outright exposure. The fearful are caught as often as the bold. So the most important thing here is you have to confront your fears. Similarly, if you face aneurysm rupture again and again, you will know how to tackle it. So one of the greatest discoveries a man can make, one of his much to his great surprises, is that to find that he can do what he was afraid that he couldn't do. Now it's also important to understand the strategies to tackle with good preoperative planning. So like Marie Curie says that nothing in life is to be feared, it is only to be understood. And now is the time to understand more so that we may fear less. So thank you very much again for this opportunity.
Thank you. I only would like to add here that at least in my practice, I would do the proximal dissection of the artery before I reach to the aneurysm. And if in young people, at least, we would put an elective temporary clipping and as shorter period as possible. Otherwise, Dr. Sharad has shown all the techniques and methods to how to tackle with the ruptured aneurysm.
Sir, may I add, sir?
Yes, please.
Sir, I would like to say that means as you have highlighted the importance of elective temporary clip, kind of sometime back in from PGI, we did a kind of prospective multivariate study of all the factors which affect outcome in relation to intraoperative rupture. We noted that whenever we apply temporary clip electively, the total temporary clipping time was shorter and the outcome was better rather than when the clip was applied after the bleeding has started. So, we had published that in Acta Neurochirurgica, and the conclusion was that elective temporary clipping makes the temporary clipping time shorter and significantly improves the outcome rather than a kind of rescue type of temporary clip, which is usually longer. Because
आपकी तरफ से हो रहा है
under a
सर, you are
controlled
panelist only sir. नहीं, I think वो सर वो आपकी तरफ से ही है. Ask to आपकी तरफ से हो रहा है सर. That is from your side. That is from your side. हाँ, yes sir, yes sir. हाँ, I can hear sir. I can see you also in panelist screen.
Anil, by telephoning, the discussion is being.
सर अभी unmute हो गए सर आप. अभी unmute हो गए सर. हाँ, हाँ, yes sir. अभी unmute हो गए सर आप अभी. नहीं, आवाज नहीं आ रही है सर.
अनिल, तुम अलग जाके बात कर लो इधर. Yes, Dhandapani, continue.
Sir, yes, sir. Means I just wanted to kind of add to what you had commented, that we had kind of demonstrated what you said is true, that when we do temporary clip electively, the overall clipping time was shorter and the outcome was significantly superior compared to when the temporary clipping was a rescue measure in which the overall outcome was bad. So our conclusion was it is always better to do a short elective temporary clipping, have a good dissection of the neck, and then if necessary, I think Dr. Mathuriya sir, he always recommends a kind of tentative temporary clip just away from the neck so that we can have more control. So, sir, you want to add, Dr. Mathuriya sir?
Mathuriya. Is not there or is there?
Sir has to unmute, I think.
No,
He's
he is
there.
there, but some problem in communication actually.
Okay.
Anyway, this is what I have practiced throughout the aneurysm surgery, and I had good results. And quick, it become very quick because, as Dr. Sharad said, you can sometimes electively rupture the aneurysm. So if the tumor aneurysm is bigger, you put a temporary clip and you rupture the aneurysm and clip the aneurysm. Dr. Kishor.
Sir, I agree with every point that is said by Dr. Dhandapani and yourself, and of course, Sharad, there a very nice presentation. I slightly have changed my practice. Over the last 30 years, I've been doing aneurysms now. Initial 10 years, I was very careful and I used to put temporary clip in almost every patient, whether it was required or not. Over next 10 years, the incidence of temporary clipping or even the rupture has gone down. And last 10 years now, me and my couple of colleagues who are vascular neurosurgeons, we clip about 2 aneurysms per week. We don't use temporary clip, or we try not to use temporary clip at all nowadays. And second thing is our rupture rate is extremely low. That's probably because we are a bit slow in operating. We always discuss and anticipate among the vascular team what the problems are going to be. And I think even the cases that Sarat described, I think now in the retrospect, if there's an intraoperative rupture, I tell my registrars and fellows, it's almost always a preventable technical error of surgery. In almost all cases, unless they're extremely small, such as medially pointing blister-like aneurysm on a carotid, unless they are absolutely challenging, your intraoperative rupture can almost always be prevented by slow and proper dissection. And I have almost given up putting temporary clips on, except when you are opening the aneurysm deliberately, electively, such as giant MC aneurysm, where you can't put a clip on unless the aneurysm is emptied. I don't put temporary clips, and the rupture rate is extremely low. So I think that's probably the evolution we have been able to achieve. I don't have any hard facts or evidence or any numbers to prove whether that has really translated into better patient outcomes. But we maintain, me and my couple of colleagues, that intraoperative rupture should be a rare complication. And second thing I do is, if I think this is a complex aneurysm and rupture is possible or clipping is going to be difficult, then I always have an expert assistant with me. He could be either my consultant colleague or my fellow or a senior registrar who just passed his training or FRCSSN exam. So it's always good to have a technical assistant who can also assist you under microscope with the same level of competency. I think it helps a great deal. If you're doing it alone or with a very junior person, and if there's a rupture, I think probably then it could be difficult. Not impossible to manage, but difficult. Sorry.
Yes, thank you. Thank you very much, sir.
We go to the next speaker.
Yes, sir. Yes. So sir is already there, sir. Please.
Yeah. Yeah. Thank you, Anil. Thank you. Good evening, sir. Good to see Mehta, sir, after a long time. Mathuriya, sir, and Kishor, sir. Yeah. I also thank the society for giving me this opportunity, and Anil had given me a very tough topic which I was telling you, but nevertheless, I think I'll do justice to the topic. So my topic is on microsurgical clipping in failed ETV. So the definition of failed ETV varies. So it could be technical difficulty intra-procedural, where in the cath lab some things are not going well and they have to back out and we have to intervene. Or the procedure is done, but there is a significant remnant for various reasons. So we expect that this patient has to be retreated after a later point of time. Or there's a satisfactory outcome occlusion, but then there is a recurrence after some time on radiological follow-up and coil extrusion. So all this can be defined as EVT failure, and these are different scenarios. And now coming to the first point, why what procedure complication can happen wherein the endovascular colleagues can back out. So one thing is about the inability to catheterize the aneurysm due to the shape and the morphology of the aneurysm as such. Let me show some of the examples. And the other thing is sometimes severe vasospasm, so they're unable to proceed with the guide wire, guidings, and they have to back out. Significant vascular tortuosity, where they feel that it may be risky and there'll be a lot of meddling of the vessels. It can incite itself vasospasms, so they back out. Or a significant thromboembolic complications, intraprocedural, or there's an intraop rupture rate. So all these things are reasons for sometimes doing the intraprocedural difficulties. So now the concept is that whenever there is a problem, I think the discussion had happened. Dr. Kishor was also mentioning in this discussion. So whenever there is a problem, so it's always better to have a backup in the neurosurgery OT. The surgeon is also ready so that the patient under the same anesthesia is shifted to the OR. And if it is a hybrid theater, it's well and good. But if their place is not hybrid theater, then we can shift the OT. Patient is anyway anesthetized, and we can complete the surgical procedure so that the outcome is much better. That actually prevents complication, reduces the rebleeding rate, and also there is no need of repeat anesthesia. But however, patient should be in the good shape, and there should not be major significant deficits, and also the endovascular manipulation are relatively minor, so that a surgical complication is much less during such scenario. So I just take you to some of the examples wherein sometimes this has to be backed out and we have to step in to help our endovascular colleagues. So this is around 45-year-old male who had this and ruptured large fusiform MCA M1 segment aneurysm. As we see that the neck was quite wide, and the endovascular colleague, he went in and he tried to coil it, and he had a backup plan of putting a stent-assisted coiling. And however, the stent was not able to retrieve. But what we see here is that as he started coiling, the coil started collapsing outside. And so he didn't deploy the coil. He took it out and then he backed out and saying that this may be too risky to go ahead, and then patient can develop a stroke. So he backed out and then requested us. So this patient was now with us. Now you can see that this is quite a wide aneurysm. So what we thought is that we may do a temporary trapping and then reconstruct with this a long straight aneurysmal clip. So that was in the back of our mind. So we went ahead, and I'll just take you to this video. So this is the large fusiform aneurysm. So this is the proximal, and that is so we trap the aneurysm, and then we electively puncture the sac so that we can decompress the sac, and we'll be able to reconstruct it as per plan. So we can see that the aneurysm sac is collapsed, and so a long straight clip along the parallel to the parent segment, so that we can reconstruct the parent vessel without compromising the lumen. So always the lumen was seen, and we made sure that the clip does not compromise the parent lumen. So as we see here, so the long straight clip which was going parallel, at the same time it was reconstructing the vessel. So we deployed it, and then we made sure that the aneurysm was taken care well. So this is the, you can see that this is the clip, and there is a small nerve off here and this sac here, but we sort of accepted it, and however the aneurysm is taken care well. He's now almost 4.5 years follow-up. He's doing well, and there is no any deficit, and we are advising for an angiographic follow-up annually. I just take one more example. So this is a young girl. You can see this is an 18-year-old female. It was a dysplastic giant MC aneurysm, and it was unruptured again. She had some headaches, and so the vascular colleagues went in. And as we see that, once he started catheterizing inside, the vessel went into severe spasm, and then he couldn't proceed anything further. So he backed out, and he asked us for help to do something more. So then we didn't do immediately. We shifted the patient back to ICU, and we reevaluated her. We can see that, and there is also a large thrombus there, and we can see, and we did a repeat angiogram. We can see that we're not sure whether the aneurysm was filling, but we went ahead, and then it was causing a lot of mass effect, and she was drowsy, and so we went ahead and excised the sac completely, and the parent vessel was completely occluded. It was the progression of the thrombus happened into the MN retrogradely. So what we thought is that she may go in for a large MCS stroke. So I sort of did a decompression, large wide craniotomy, left the dura open, and so that in case if he develops a stroke, but the STA, we planned for an STA bypass, the MCA vessels were too narrow and too small. So we just did a decompressive craniotomy, and then, but however, she did very well. After 3 weeks, we did replace the bone flap, and now it's almost 10 years now. She's going back to the college, and she is doing very well, extremely good. There's another case of difficulty in cannulating, which you can see that this is a quite large ICA aneurysm, and we can see that this is the afferent and the loop, and this is the efferent loop becoming the M1, and we can see that this. So the plan was to deploy a flow diverter, and because this is too small, so however, intraprocedurally they are unable to put the optimum catheter to get in a proper flow diverter position docking. So they decided to come out, and then they were asked if we can do so. We went ahead and we trapped the aneurysm and put a straight clip and like this, and we completed and secured the aneurysm. She was in her 50s, but then she didn't have any issues. She recovered quite well. And so these are some of the scenarios where we can help and working together. Sometimes this is a case where this is a very interesting case. So she was in her 60s, and she had this large aneurysm, and our colleague had started packing the aneurysm, and as he deployed more coils, the other segment, other wall of aneurysm started expanding in the other side, and more coils he deployed, the aneurysm started expanding further. So we decided that we should stop this procedure at this point of time, and we didn't have time. We were very afraid that this is any pseudoaneurysm, so it may rupture immediately. So we went straight, took her to the OR, and we decided that we sacrificed the aneurysm, and we went ahead and did the high flow bypass using saphenous vein, and this was the intraop ICG. You can show that the saphenous vein is filling well. Then we trapped sort of aneurysm, and we did an angiogram. We can see that the thing is filling very well, and then you can see this is the final appearance. We confirmed that the angiogram or graft was working well, and then we decided to knock down the parent vessel as seen like this. So these are some of the scenarios where we really can help. And again, so this was again a case of a large cavernous ICA aneurysm, and we can see that though the neck was looking quite small, but then we went inside the whole neck. The neck was very, very wide, and it was quite dysplastic. And that time, this was almost 8 years back. So the flow diverters had just come, and then they're not confident of deploying, telescoping one other flow diverter. So they backed out, and then we went ahead. And she had unfortunately very poor cross circulation from the other side. The BT, she didn't fail the BTU. So we went ahead and did the high flow bypass, and we sacrificed the parent vessel. Tortuous vessels give a tough time, and so it's like this. So she was in 77 years, so she had this massive rupture of the PCOM segment aneurysm, and this was the aneurysm. We can see there's quite a dysplastic one, the wall, and this was a fatal PCOM. It was a rising distal to the neck, and our endovascular colleague decided, but the vessel tortuosity was too much, and so he was not confident to go ahead and do this clipping and safely securing the aneurysm. And even then, he was told that he had to leave behind, so he backed out, and then was requested as if he can do a clipping of this aneurysm safely. So our mind, what we planned is that the fetal PCOM has to be preserved. So we thought we will put a clip like this so that we'll accept this neck so that this PCOM can fill through this. So that was our plan in our mind. And this was the just a video. We can see that this looks quite large. We can see the whole ICA was display atheromatous. We can see quite a large, and we wanted to put a large. It was large, so we decided to trap the aneurysm and, if required, puncture also, so that we can safely deploy the coil, a clip as planned. And we decided to go in, and we can see that this is the fetal PCOM. We put a clip on the fetal PCOM also. So what happened during the procedure is that you can see. So the clip was going in, so quite large clip as planned, but then there was a procedural complication, but we didn't remove the clip. We deployed the clip, and because we want to preserve the anterior choroidal also. So this was the anterior choroidal, and then we saw what was bleeding, because we thought that we have clipped the aneurysm completely, and then when we tried to reserve, we can see that probably some part of the small neck got avulsed, and it was bleeding directly from the ICA lateral wall, just between the PCOM anterior choroidal segment. So what we decided that we just pushed in the small nubble of the neck and tried to approximate. Luckily, we had trapped the aneurysm so that, but still then there was a cross flow because probably that was the rent. So we tried to push that small residual neck across approximated to that and the bleeding stopped. So we put one more clip, booster clip, including that nerve, and we protected the aneurysm, and we can see that. So we could save also the anterior choroidal, and we could salvage this procedure, and we removed the clips, and we can see that. So we removed all the and made sure that the aneurysm was not bleeding. So there was a large fetal PCOM. So we can see that the fetal PCOM was also taken care, and this is the final position. And then we put some small. So this is an elderly. Ideally would have preferred to do coiling, but because of these scenarios, we went ahead. And so this was the post-operative angiogram. We can see as per the plan. So we could preserve the fetal PCOM, and the aneurysm was taken care. She recovered quite well. The other major topic is about the recurrence after the endovascular treatment. So now that the incidence of endovascular treatment has gone significantly higher, but then also we see that a lot of these cases also do come back the recurrence. So the incidence literature suggests that almost 20%, 1/5 of all coiled aneurysms recur at some point of time. So they need close angiographic follow-up in a longer period of time, and approximately 1/2 of that will require additional intervention. So the long-term, more we follow up, we find that the recurrence can be as high as 50 to 36% in various literature, and the most common cause is initial incomplete aneurysm. Sometimes it can be a complete initial occlusion, but then coils can compact and can regrow, and that is some of the causes. So what are the factors which lead to recurrence? So the size and neck of the aneurysm, the wide neck aneurysm, you may not be very confident to pack it tightly. There can be coil compaction and ruptured aneurysm, if you coil, always it is a suboptimal sometimes, so they can compact and then they can come back. Initially incomplete occlusion, again, packing density matters, whether the stent was used or not, and the more you follow, you find that they come back. So this is now the classification. So it can help us in the decision making when these patients come back to us. So we can see that the height less than 2 millimeters from parotid vessel, and the height millimeter more than 2 millimeters, and then we can see this is significant coil compaction, and we can see the coil migration just to the neck and also to the parent vessel, and sometimes into the subarachnoid space. And here again the coil compaction. So the width of the aneurysm as well as the height ratio is very important, and loose coils. So these are some of the indications where then we need to go in again and treat them because they are still prone for rupture. And what are the options now available for these patients? One can do recoiling, and they can do stent or stent-assisted coiling. Now, however, with the advent of flow diverters, a lot more of these aneurysms are now subjected to flow diverter rather than risking these type of other procedures. So flow diverters, in fact, has replaced many of these recoiling techniques, and just they deploy the flow diverter and it takes care very well because these are anyway unruptured aneurysms or they are unstable aneurysm which can be done. So now the question is, if these patients, whether to treat these patients residual aneurysms after the endovascular treatment. So if you see the literature, the annual re-rupture rate after the coiling is not very high. As general population, we say that around 2.5% rupture rate. In these cases, the rupture rate is not very high. That is why many times they follow it up without doing much intervention. So because of the low re-rupture rates, and however, if this remnant is quite non-progressive, it is fine, but if it is an unstable residue, then the risk is quite high. These are the patients who definitely need treatment, and they just cannot be left alone like that. So the endovascular retreatment have a retreatment rate. If you want to treat them endovascularly, the retreatment rate is around, as I mentioned, not all cases. There are select of patients who undergo and aneurysm with previous coiling alone, stent-assisted coiling, or flow diversion, as I mentioned earlier. So what are the complications of redo endovascular treatment? The most feared complication, of course, is the thromboembolism, which can range up to 0 to 11%. Even after the retreatment, there can be recurrence, and that is actually higher than the re-surgery. If you want to do clipping at the recurrence of endovascular treatment is quite higher. It can still recanalize, and the re-treatment for that also. For that, I think the surgery has a little higher risk, so they prefer to do endovascular re-management. But is there a role of surgical clipping in these cases of fail? I should admit that with the advent of flow diverters, majority of these cases are again being done by endovascular methods, but there are some group of patients who do come refer for surgical clipping, and the clipping of previously coiled aneurysm is sometimes complex. Or Sarat Chandra showed in one of the video how the coil is so extracted and then he has to reconstruct it. So removing of the coils and then the intraluminal thrombus and to securely place the clip at the neck is sometimes can give to problem, and we need to take a decision on table as how to do. So the surgical treatment can be surgery for the residual neck. We can do a straightforward coiling, or we can do a 5-flow bypass as shown in one of the cases. If the neck is less than 2 millimeters, this is a stable residue, we can probably wait and do angiographic follow-up and do nothing and just follow it up. However, if there's a compaction like this and there's a significant neck, then this is one case, or if there's a pseudoaneurysm, something like this beyond the neck, I think these are the cases where we can do direct clipping. Or if the neck is too small, we can also do muscle wrapping with the cotton or muslin wrapping, which is also an equivalent option. It can induce fibrosis and can protect the neck if there is no place to put a put a clip. Sometimes we need to see that if it is, these aneurysms cannot occlude. So Dr. Sarat Chandra in his talk showed that clip, sometimes the opening pressure is quite good at the tip, but not at the base. So if it's not secured well, still the coil, it can see, aneurysm can fill back. So this is called a double hit technique, where we can put one fenestrated clip, and also we can couple with a straight clip so that the whole aneurysm can be taken care very well. Sometimes we need to do a removal of the coil and then place a clip. And unfortunately, I didn't have the video of that. So we can see that. So we have to remove we can put the question of whether to remove the coil and put a clip is based on whether we are able to put a clip safely along the neck. So we can trap the aneurysm, try to open the sac, deliver the coil as much as possible, just to take care of the neck so that we can pass a clip like this. The question of whether the safe to remove these coils, it all depends on the temporal profile of the event when the patient underwent causing. Anything between 4 to 8 weeks is a safe period, but if some patient it is beyond 8 weeks, as documented, there are a lot of endothelial cells has grown in the clips, so coils, so it can be completely adherent. There's a high risk of rupturing the vessel and damaging the intima, and this can be a problem. So it is very much important to know when this patient underwent coiling, and if it is more than 8 weeks, it's very, very risky. It can create problems while doing so. So the best for such cases is to trap it and then do a bypass, which can be a better option and a safe option, rather than risking removing the protector coils and causing damage inadvertently. So surgical clipping of a previously stent-assisted coiling is not much of literature available, and it's quite riskier more because the technical challenge is much higher, and temporary clipping becomes difficult because there's a stent in place, and sometimes after removing the stent, the vessel lumen can get distorted. So we don't have much literature on that. Probably time will tell us whether this is a safe procedure, but nowadays endovascular colleagues prefer to do a flow diverters as a telescopic technique in such cases. So these are some of the cases where endovascularly can fail, and then if anything like this can be safely done, but if it is prolapsing significantly, we may have to remove the coils to do the necessary. Sometimes what you see is a delayed complication and management, as in just to see one case. So this is a young lady who had a large cavernous segment aneurysm, and she went to parent vessel occlusion, and she did well for 5 years, and she started having symptoms of TIA, and as you see that the aneurysm was taken care, but we can see that the MRI shows mild shrinking of this side, left side, and she had intermittent TAs, recurrent TAs. We just had, because more of a hemodynamic stroke. So we did a follow-up imaging. The cross flow was not great, and however she managed to have 5 years without any problem. This came a little later, and not much cross circulation from the posterior circulation. There was capillary delay. So what we did is we did a diamox challenge, and we demonstrated that the perfusion was much less in the left hemisphere compared to the right side. So we went ahead, we did an STMC bypass on the left side, and then this was 6 months later, the perfusion improved on the left side, and she also became asymptomatic. So sometimes these type of delayed complications can occur. And so to conclude, failed endovascular treatment is a concern, and we will be seeing a lot more cases because more and more aneurysms are now done endovascularly rather than microsurgical clipping. We have a lot of modalities available, and repeat endovascular treatment is the one which is preferred by many. They do re-endovascular treatment, but there is a role of surgery in these patients, and it can do either clipping or we can do bypass depending on the case. So sometimes removing the coils and then do the clipping is also an option, but it has to be on a case-to-case basis, the temporal profile of time, because at the end of the time, patient's outcome should be better. We should not damage them. Thank you very much for this patient hearing.
Thank you very much, sir. Wonderful talk as usual, and it's really a treat to watch your videos.
Thank you, Anil. Thank you.
I'll request
Hello.
all esteemed
Hello.
for discussion.
Hello.
Yes,
Hello.
sir.
Sir, Mathuriya, sir. Sir, go ahead, sir.
Can you hear?
Yes, sir.
Yes, sir.
Yes, sir.
I am sorry, actually, that
You can
there
show
was
your
some
videos
problem in
also.
connection.
No issue, sir. Go ahead.
Say number one is that about the endovascular coiling, the antiplatelet can these be given prophylactic, and this tirofiban IV infusion can be given prophylactically to avoid the thromboembolic complication.
Yes.
This is from Dr. Arun.
Yes, sir. Yes, sir. Sir, tirofiban usual antiplatelet regimen is dual antiplatelets, either aspirin or clopidogrel, and we usually check with this Verify Now to see the sensitivity for antiplatelet reactivity. If it is poor, we can add one more. Prasugrel can be added. Tirofiban and other GP2B3A inhibitors are used intraprocedural. Whenever there is a thromboembolic complication intraprocedural, that time either you can give intraarterial or intravenous.
Then what is the mortality about the patients in whom there is an intraprocedural rupture?
Yes, sir. That one slide we had, one study was done, sir. There is almost 4 times increase in mortality compared to surgical. Surgical intraprocedural rupture has 2 times increased mortality, whereas endovascular.
I'm not talking of how much surgical and how much about the intervention. Percentage mortality in the intraprocedural rupture patients in neurointervention. Hello.
35 to 36%, sir.
It's around 40%.
40%.
Whereas in surgical, it is around 90.
Sir, your voice is muffling. Maybe some disconnection. Anyway, Professor Mehta, sir, to comment on Dr. Roopesh's talk.
No, it's a absolutely very nice talk. That is what I would say. And he has covered all the complications of the intervention and their how to tackle them. I think it's excellent work. Thank you.
Thank you, sir. Thank you.
Dr. Choudhary, is he there?
Yeah. Lovely talk, Roopesh. Very nice. The only thing I would comment is I was just saying after the previous presentation about use of temporary clip in the 77-year-old with a PCOM aneurysm with a dominant PCOM. I think you had put a temporary clip or trapped the aneurysm before even dissecting the aneurysm. If you see the vessels of that lady, they were so thick wall and atherosclerotic. I think in such patients, I would be very reluctant to put a temporary clip on prophylactically, simply because it can dislodge the thrombus inside, and apparently after a very nice operation, your patient can end up being stroke. So I would just be a bit careful about that. Also, another thing that I do in my practice is that when there is a recurrent aneurysm that has been coiled and there is a progressive coil compaction and you are taking the patient for surgery, many a times you find that it is practically impossible to remove the coils because they are virtually embedded in the aneurysm wall. So unless you excise the aneurysm, it is impossible to remove the coils and clip it properly. So what I have done is that if there is a reasonable neck, and even if there are some coils within the neck as well, that I don't bother removing the coils at all. I just put a clip on, even if it means an incompletely obliterated aneurysm. So I put a clip on. I might put another additional reinforced clip on and not occlude the aneurysm completely, but decrease the flow into the aneurysm significantly. And if I'm convinced that I have achieved that, I think most of the times you will get away without a re-rupture. Because that is, as you pointed out, the re-rupture rate after coiled aneurysm is extremely small. And if it is not progressively compacting aneurysm coils, then the re-rupture rate is even smaller. So all you have to do in difficult cases that you have just to reduce the blood flow to the half and you will get away, because after reduction of blood flow, that aneurysm with the remaining coils will thrombose and you will have changed the dynamic of the aneurysm enough to stop that coil compaction being progressive. Do you know what I'm saying? And I do that very often. So I don't try to take heroic steps or excising the aneurysm or reconstructing the vessel wall by sutures or anything like that. I'm also a bit reluctant to do bypasses because in my hands, at least, the bypass patency rate is not as good as I've seen across the world. So I try to do that and find an easy way out where you have achieved the objective. At the same time, you don't make something heroic or difficult.
Yeah. Is there a risk of a parent vessel prolapse of the clips into the parent vessel, causing narrowing of the parent artery?
Well, the way you put the clip is you should put it parallel to the parent vessel, full stop. So it will not cause parent vessel obstruction. I mean, the whole purpose is not to let the parent vessel be obstructed.
No, because with the clip, with the coil in the neck and there is no place, if you try to put a clip, it can slip out into the parent vessel. That's what I mean. You understand?
No, it shouldn't actually, because the way you put the clip, I think matters. If you put it across, I think it should not slip unless it's a very, very wide neck aneurysm, and then it becomes very tricky, but it should not slip. And sometimes I use the parent vessel wall to hold the clip. So if your clip is parallel and actually sitting on the parent vessel, then probably the chances that it will slip onto the parent vessel is small. But I agree, I take that point. That is a big risk. And that can very easily happen because you are not able to collapse the aneurysm because of the coils. And the neck, you are not able to collapse even after a clip. So then I would put a clip more distally and more distally, sometimes on the body almost, and make sure the flow in the aneurysm is reduced. That is the aim, essentially, isn't it? The aim of the aneurysm surgery is not occlusion of the aneurysm. The aim of the aneurysm surgery is to prevent rebleeding. And so sometimes I'm happy to accept a suboptimal result because, at least in my hand, I don't find that I can get an excellent result all the time consistently. It doesn't happen.
Yeah, your other answer for that question, why we used a temporary clipping for that elderly lady. I was also quite reluctant seeing that yellow color vessel. Usually I avoid clipping because there's a risk of thromboembolic complications. Displacement of nephromatous plaque is quite high. But in this particular patient, what we saw that there was no space at all. The pecum segment was filled with the sac, and I didn't know where the anterior choroidal artery was. So, and it was a ruptured aneurysm. And if I could see when he retracted the temporal lobe, the fundus was so thinned out, and I could literally see the blood flowing in. So I was very afraid that I may produce a disaster by doing blindly. So I safer side, I wanted to trap it so that everything is controlled. But despite that, probably because of the atheromatous vessel, even after trapping, there was still bleeding. So that is because the clip was not holding it because of the atheroma in the ICA.
Yeah, I can take the point. I think Robin Sengupta used to say that posterior communicating artery aneurysms are either dead easy or easy dead. So I can understand.
Yeah, that's right.
There are few questions, sir. So I think we can take few questions from the audience. Dr. Tusan, he's asking why triple S therapy has fallen into disrepute post clipping or post coiling these days as compared to 20 years back.
Can I
Yes.
answer the question? I think it's probably not in disrepute. I think Triple H therapy does work, but then over a period of time, we have realized that there are significant complications associated with overloading patients, especially if they are in the elderly group, or putting their blood pressure too high as well. It has, nothing is without complication. Any intervention we do, any manipulation we do is not without complication. And as far as I'm concerned, I think in all my patients, we got a terrific, very good HDU and ICU that is managed by combination of intensivists and physicians and neurosurgeons. And what we do is that we use triple H therapy, but not to push the blood pressure or the fluid to an extreme limits. We just use it in moderation. In fact, the corollary is that it's important to avoid hypovolemia and to avoid hypotension rather than to push the blood pressure up and the fluids up. And I think it works. I think in the long run, probably your complication rate from delayed vasospasm will not differ much as long as you use the triple H therapy very judiciously. That's my take on it. It's not in disrepute. It's just we are more wary of it's not the solution to all the problems. That's what we've realized for the years.
What we do in our setup is that we follow the patient with the transcranial Doppler every day. So even the patient shows increased velocity, but then the patient is asymptomatic, we hold on. We don't allow the patient to dehydrate. Like we just keep a positive balance, and especially because sometimes ACOM, they can have probably DA or CSW. So we need to just make sure that they don't go for dehydration and keep them in U balance. But if they demonstrate a clinical slow deterioration in sensorium or some mild weakness, then we chip in and then raise the BP, increase the MAP, and follow up TCD. So that's what we do. So it's never a disrepute. So as you have pointed out well, so it has to be done judiciously. It's not blindly. And delaying the inotropes at a later date when the patient, we can have a window. Otherwise, if we start much earlier, patient gets acclimatized. And then when the pressure needs to be higher, that time we need to be on so much medications would be required. So we just avoid. So we don't treat angiographically, but when the clinical vasospasm, we definitely induce hypertension by giving inotropic noradaptation.
Absolutely, yes.
Another query is current status of using dexamethasone in aneurysm surgery.
I didn't know we use dexamethasone in aneurysm surgery.
I don't use.
Yeah, here many institutes in I think India we do use because we do not know the reason for the vasospasm, why some patients. So whether any inflammation comes in, is there any role? So we give, because we don't have a data on that, but still we still follow many institutes. I think my parent institute, we used to give dexamethasone, and subsequently where we practice also, we give a small dose of dexa at least during the peak period of vasospasm, and just to make sure that the arterial inflammation subsides, because we do not know real pathogenesis of vasospasm. So we think that there is some amount of an inflammation which can lead to. Mehta sir, what is your take on steroids, sir?
No, as far as triple H therapy is concerned, I totally agree with what both of you have said. As far as dexamethasone is concerned, God knows whether it acts or not, but this as we said, we believe that it helps in the brain protection and all that. So many centers use it very regularly.
Another question from Dr. Sachin. Stent-assisted coiled aneurysm shows progressive coil compaction and pseudo-neck progression. So what are the options to manage?
So that's what I showed in my last slide. We don't have much literature. Actually, I went through the literature and to just find out what are the other options. So this particular stent-assisted coiling is a real problem. What some endovascular colleagues do that is that they deploy telescoping. They deploy a flow diverter through the stent and try to sort of protect the aneurysm. And because the clipping the stent-assisted vessel, parent vessel with the stent doesn't occlude properly, and sometimes if it occludes also it deforms, it will not open up again. So there is a real risk of putting a temporary in the stent assisted coiling. So we need to have wait and see what is the future. But I think FD can probably solve, because these aneurysms are better done endoluminally rather than from.
Are there any Indian-made flow diverters available that are cheaper to use and are freely available to use in population?
No, sir, we don't have yet.
No, recently I think they've started making recently.
But is it in use? I'm not sure.
I'm not sure about name, but I think I came to know like recently somebody has started.
Okay.
One or two
And-
companies in India.
And in central institutes, most of you are working, and in corporate hospitals, are the flow diverters easily available? And when the patient is not affording, can you get some grant or any assistance where we can get them and get the flow diverter if that's necessary?
No, I think it varies from center to center, sir. In many center like in Delhi, it's freely available in many of the institute like Safdarjung and GV Pant and all. And other institute, many schemes are there, like some Ayushman and some CM relief fund or something. So it can be managed at majority of the centers. I think so.
Most of the corporate hospital, I don't think it's simple.
Yeah, because there is a cost to the
Yes.
much more than what it is. So unless patient has insurance and they can afford, it's difficult.
Then it's a cost.
So one more question, sir, from Dr. Mohana. Adenosine arrest importance.
Adenosine arrest. You should have the adenosine in place, and our anesthetist should be comfortable. If it gives, of course, a very short half-life, so we have very less time, probably 20 to 30 seconds. We need to make sure that we protect the aneurysmal sac, and otherwise it can cause reblown bleeding again. So if you know that if we can handle the aneurysm in that point of time, then it's better to give adenosine. Wherein, example most likely is that if there is a ophthalmic artery segment aneurysm, and if there's rupture, we cannot put a temporary clipping beyond, we are not able to see, or if PCOM is very close to the collateral segment where there is no real space to put, and if there is a rupture, probably that is a case where we can use adenosine to produce a temporary bleeding, and then we can quickly dissect the neck and then put a tentative clip on at least, and then put a permanent clip.
Sometimes for these patients, I always I keep the neck opened or at least prepared, or where you can get proximal control to the proximal ICA outside the cranial cavity, so that then, because the risk of adenosine is quite sometimes high, and you can get unexpected complications from the acidosis as well. So I think it is much easier to just keep your ICA exposed in case you are worried that you will not get proximal control in ICA or ophthalmic aneurysms. But that's, of course, every individual's preference.
Professor Mathuriya is on line. I think he wants to.
Yes. Actually, I'm sorry that I could not connect for a long time. And it has gone for a quite long time. Is it possible that I can give few comments?
Oh, yes, sir.
Yes, sir. Yes, sir, please.
See, the thing is that one about the clip, Yasser clip, which is told that the tip has got more force as compared to that at the hub. It's not like that. Actually, what happens that the Yasser clip, the portion which is close to the hub, a very small portion which is close to the hub, that doesn't have those fenestrations, so that part of the clip doesn't clip. So when you are putting the Yasser clip, the force is always there in the middle part quite a lot. At the tip it is less, but the initial part of the hub probably may be about fraction of the millimeter. That portion doesn't have the serrations. That's the reason that a small portion doesn't clip. So there you have to put some another clip, and then you have to reinforce it. That is one part. The other is that say when you have if the aneurysm ruptures and by that time you have not dissected it, we can put a tentative temporary clip, because the reason is there are many small vessels which we have not dissected off the aneurysm. If we put a temporary tentative clip there, that is not going to occlude those vessels permanently, and then we do the dissection and apply the clip. That is another thing which I wanted to tell. Then say the neuroprotection. When we are putting the temporary clip, at that time we can give the neuroprotectants and all, which everybody is aware of. The anesthesia people will know better about it. And the temporary clip can be placed for a shorter time, maybe about 4 to 5 minutes. That's what I do. That 4 to 5 minutes temporary clipping, then reperfusion for about say 5 to 7 minutes, and then again temporary clipping. If you are doing the elective temporary clipping in a patient, in that the temporary clipping even for 20 minutes is not going to cause problem. If it is intermittent, done for 4 to 5 minutes, and the reperfusion time is about say 5 to 7 minutes. That's what Dr. Dhandapani was telling. Probably that also has got a relevance if we are not very confident and you want to put the temporary clip earlier, that also is justifiable. Unless it is quite an increased thing, then it's a different story. Then Dr. Sarat Chandra has told about the Debicki's clamp. Actually, these are described by Dr. Jua Harnesnimi, that if there is a thick-walled aneurysm, these usual temporary the clips will not hold. These are not going to cause the complete occlusion. So he has devised Debicki's detachable clamps. So that has got a far more force. So that will occlude the lumen and then you can detach it. So it can be left inside. Then about the say the triple H and double H, the triple H therapy, it's no more in vogue. The hypervolemia is not done. It is the hypertension and the hemodilution. That's what is done. Then to avoid the rupture, what we do is that when we have done a CT angio along with the clot, what we do is that we visualize the clot on the 2D CT angio and see that where the clot is in contact with the aneurysm, that portion we take out the clot last, so we avoid the rupture. And that's what I wanted to communicate. Thank you very much.
Sir.
Thank you.
Thank you, sir.
And
Arun? Anil?
anything more, Dr. V.S. Mehta want to add?
No, I think everything is added. Thank
Anil,
you.
is there any more questions?
I think it's done, sir.
Okay.
That Dr. Mohana has commented that flow divert is Merrill. Merrill flow diverter is available.
Okay.
Okay.
Yeah.
Okay.
It is the Indian one, is it?
Yeah, Merrill is Indian.
Yes, I'm not sure. So,
Okay.
any other comments from?
I, on behalf of the Cerebrovascular Society, thanks Professor Mehta and Professor Mathuriya, the former president of the society, to join us and give valuable comments, and Dr. Choudhary from UK and Dr. Dhandapani from PGI. And I really appreciate the talks of Dr. Arun, recorded version of Dr. Sarat, it was good. And finally, Anil was wondering who will be the last speaker, and he messaged me, and suddenly came to my mind Dimox study by Roopesh. So I ask Roopesh if he can make it. And it was a wonderful talk by Roopesh.
Thank you.
I thank you all, and hope we will continue educating our members. And finally, I'll congratulate Anil for his labor to keep on going. I think this will be the end of aneurysm section of Cerebrovascular Society. We will next onwards we will move on to arteriovenous malformation and the fistulas and all these things. Thank you, sir. Thank you all on my on behalf of Cerebrovascular Society. We are honored.
Thank you.
Anil?
Thank you very much, sir. Thank you very much, sir.
Thank you, sir. Thank you, sir.
Congratulate all.
Thank you.
Sir.
Oh, thank you. Thank you very much.
Thank you, sir.
Yeah.
We stop here.